Hey guys, welcome back to my channel, The ENT Resident. Today our video is gonna be of the third part in our series of complication of CSOM, and today's topic is intracranial complications of CSOM. You can also purchase my notes now. I have added links in the description. Okay, so let's get started with our first complication, and that is extradural abscess. Now, what is extradural abscess? As the name suggests, it's a collection of pus that is located outside of the dura and between the bone and the dura. If you see in the image over here, we can see that this is the dura mater and this is the bone. So a collection of pus in between them is the extradural abscess, also known as epidural abscess. Now, this can occur as a complication in cases of acute otitis media as well as cholesteatoma as well. And this is an intracranial complication which is usually seen to coexist with other intracranial complications. And this can also serve as a precursor, or rather, it can precede the development of brain abscess as well. Now, let's try to understand what is the pathology over here. So, if in case it is developing from a case of acute otitis media, the bone over the dura gets destroyed by hyperemic calcification. And if it is a case of cholesteatoma, in that case, the bone gets destroyed by enzymatic activity. Now, if you want to know more about how the bone erosion happens, I have a separate video on cholesteatoma on it. You can check it out over there. So, as a result of this bone destruction happening over the dura, now there is a collection of pus that occurs in the epidural space. So, this is one mode of development of this disease. The second way is in case the spread of infection has happened by thrombophlebitis. In this case, we'll see that the bone over dura remains intact. It is not destroyed at all. The affected dura that we see over here usually ends up getting covered with a lot of granulation tissue and it appears very unhealthy and discolored. So, our epidural abscess or extradural abscess can form in different regions, like in the middle cranial fossa or the posterior cranial fossa, or it can even form as a perisinus abscess. What is a perisinus abscess? This is an abscess which develops outside the dura of the lateral venous sinus in the posterior cranial fossa. So, this is the pathology of extradural abscess. Now, how will a patient present to you in this case? Most of the times, a patient is either asymptomatic or silent in most cases, and they often get incidentally discovered during the process of carrying on mastoidectomy in that patient. So, majority patients will be asymptomatic. But other than that, the most important symptom here is a case of persistent headache on the site of the otitis media. And this headache disappears with free flow of pus from the ear. This is known as spontaneous abscess drainage. This is the most important clinical feature of such cases. Other than this, patient will have severe pain in the ear, general malaise with low-grade fever because of the presence of an abscess, and pulsatile purulent ear discharge. How do we investigate the case? We have to perform a contrast enhanced CT or an MRI scan. We'll be seeing that there is a dural elevation which is indicative of extradural abscess. Coming to treatment of this, you should definitely start on IV antibiotics before and after the surgery. And you'll have to perform mastoidectomy. In mastoidectomy, what you do is the overlying bone is removed until the healthy dura is seen. And in case of a strong suspicion, if the overlying intact tegment tympani or sinus plate is still there, you need to remove it to evacuate any collection of pus. Post surgery, the patient should be very closely monitored so as they do not end up developing any other intracranial complications like meningitis, brain abscess, sigmoid sinus thrombosis, etc. So, this is all about extradural abscess related to CSOM. The next complication is subdural abscess. As the name suggests, subdural abscess is the collection of pus below the dura, between the dura and the arachnoid. You can see in the image over here, this is a subdural abscess. You can see that this is the dura mater and this is the arachnoid mater. Now, the pathology of this disease is the infection in the ear. It starts spreading by either erosion of bone and dura, or it goes via the thrombophlebitic process, in which case the bone will be intact. Now, once it reaches the subdural space, it comes to lie in contact with the convex surface of the cerebral hemisphere, and it starts causing pressure symptoms over here. And over a long period of time, the pus may get loculated at various places inside the subdural space. Now, what is the typical presentation of this case? When a patient comes to you with a sudden, unusually severe headache, which is usually associated with fever and vomiting and rapid deterioration of the patient, you should definitely be suspecting a case of subdural abscess. Now, all the clinical features that we see in a case of subdural abscess are due to three reasons. Either it is due to meningeal irritation, or due to cortical venous thrombophlebitis, or due to raised intracranial tension. Now, let's find out what are the different clinical features that we see because of each of these reasons. Now, because of the meningeal irritation happening here, because of the collection of pus, the patient will complain of headache, fever, increasing drowsiness, neck rigidity, and positive Kernig sign. The patient will also have cortical venous thrombophlebitis. What happens here? The veins that is present over the cerebral hemisphere, they end up undergoing thrombophlebitis. And as a result of this, the patient can present to you with aphasia, hemiplegia, hemianopia, and even Jacksonian type of epileptic fits, which may or may not end up progressing to status epilepticus. Last of all, because of the raised intracranial tension, you'll also see certain features like papilledema, ptosis, and dilated pupil, which occurs due to oculomotor nerve palsy, and there can also be involvement of other cranial nerves. Now, even in this subdural abscess, the investigation of choice will be to perform a contrast enhanced CT or a MRI scan. The MRI will help you in distinguishing between epidural and subdural abscesses. You can end up seeing multiple discrete lobulated subdural collections. And MRI is very sensitive in the fact that it will help you in differentiating between sterile, bloody, as well as infected collection, which will not be possible on doing a CT scan. And in these cases, lumbar puncture is contraindicated. It is very important to remember this. Why is it contraindicated? It is contraindicated because it can result in the herniation of the cerebellar tonsil. Last of all, the development of subdural abscess is a neurosurgical emergency. You should start the patient on high dose intravenous antibiotics, and you perform a series of burr holes to drain the subdural abscess. And only once the subdural abscess has been treated, then you perform a radical mastoidectomy to treat the ear infection that is present. So, this is all about subdural abscess. Next, the third and the most common intracranial complication of CSOM is meningitis. Now, what is meningitis? Meningitis is the inflammation of leptomeninges. Leptomeninges meaning the combination of pia and arachnoid matter, combined with bacterial invasion of CSF in the subarachnoid space. Now, there are a lot of causes of meningitis, but in cases of infants and children, it usually ends up being a complication of acute otitis media, whereas in adults, it is more commonly because of cholesteatoma. Other causes can be temporal bone fracture, CSF leak, or middle ear and mastoid surgeries even. Now, how does this infection spread? Now, what are the routes of spread of infection over here? First of all is the presence of preformed pathways. This is something we already discussed in part 1 of our video, where we talked about all the different routes of spread of infection in case of development of complications. So amongst preformed pathways, some examples are petrosquamous suture and perineural space to the internal auditory canal via the labyrinth through oval and round window. Second pathway is retrograde venous thrombophlebitis, and third is direct erosion of the bone and dura. In infants and children, blood-borne infection has been seen to be the most common pathway of infection. So, a patient of meningitis We'll come to you with the different signs and symptoms because of two reasons. One is the presence of raised intracranial tension, and second will be due to meningeal and cerebral irritation. Now, what features will you see? Let's discuss that. So, the earliest features would be a case of fever with chill and rigor, headache, projectile vomiting, photophobia, irritability, and restlessness. These are the earliest symptoms that you will be seeing in a patient. In case of infants, they may also end up developing seizures. Neck rigidity is a very crucial symptom over here. And there are two signs that we usually see when we perform the clinical examination of the patient. First is the Kernick sign. Now, what is Kernick sign? Kernick sign is when you extend the leg of the patient with the thigh flexed on the abdomen, the whole movement ends up being very painful for the patient. This is known as Kernick sign. And second sign is known as the Brudzinski's sign. Here, when you do flexion of the neck, it results in flexion of the hip as well as the knee on its own. This is known as Brudzinski's sign. And these two are very important features of meningitis. Other than this, you can end up seeing motor deficits like hemiplegia or any other cranial nerve palsy. Deep tendon reflexes are initially exaggerated, but at a later stage, they can become sluggish or even be absent. Papilledema is a very late feature. And lastly, coming to level of consciousness, the patient can be drowsy, and this may over time progress to delirium or even coma. Now, in cases of meningitis, the imaging method of choice is an HRCT of the temporal bone, which helps you in also ruling out congenital ear malformations which permit the CSF leak through inner ear fistula. Next is MRI, which will be more sensitive. It will show middle ear fluid and any inflammatory changes in brain and meninges. Third, because we know papilledema is a feature of the disease, we can perform a fundoscopy. And on fundoscopy, we'll see indistinct disc margin and choking of vessels. Lastly, lumbar puncture. Now, what are the findings that we'll see in CSF? Before that, we should know that usually we should perform an imaging before performing the lumbar puncture so as to identify the mass effect that can lead to herniation on performing lumbar puncture. Now, the CSF in case of meningitis will be cloudy or yellowish in color. It will have a raised cell count with a predominance of polymorphs. There will be a raised protein level, whereas sugar and chloride levels will be low. We can perform a gram stain to identify the organism and also perform culture and sensitivity to find out which organism the patient is sensitive to. So these are the investigations we perform in a case of meningitis. Last of all, how do we deal with the treatment aspect? Now we have to remember in case of meningitis, medical treatment will definitely always take precedence over surgery. First of all, you'll start the patient on antibiotics. The drug of choice here is the third generation cephalosporin, usually given intravenously for 7 to 10 days. And in case the patient is not responding to the medication, in that case, you change the antibiotics according to the culture sensitivity report. Second is corticosteroids. We use that to reduce any neurological or audiological complications. Last of all, we perform a surgery. When do we perform surgery? Only when the general condition of the patient permits. So once the patient improves, usually we perform then. But if we are seeing that there is no response of the patient to the medical treatment, in that case, early surgery is definitely required. If it is a case of acute otitis media, we perform a meningotomy and sometimes even cortical mastoidectomy. In case of cholesteatoma, we perform a radical or modified radical mastoidectomy. So this is all about meningitis. Now let's move on to our fourth complication, which is otogenic brain abscess. I have already made a separate video on otogenic brain abscess. To check out more in details, please refer to that video. But here I'll just skim over some of the important points related to this. Now, what is otogenic brain abscess? This is a localized collection of pus that occurs in the brain parenchyma. And again, ends up being a complication of either acute or chronic otitis media. Now, the most common site is temporal lobe, and the second one is cerebellum. Usually, there is a bimodal age distribution seen here. The first peak is seen in pediatric age group and second peak in fourth decade of life. There is a slight male preponderance over here. The most common cause of otogenic brain abscess in children is acute otitis media, whereas in adults it is cholesteatoma. Now, otogenic brain abscess has 4 stages in its pathology. Stage 1 is early cerebritis, which lasts from day 1 to day 3. Stage 2 is late cerebritis, which lasts from day 4 to day 9. Stage 3 is the early capsule formation, which lasts from day 13 to day 14. This is the stage when we end up seeing most of the signs and symptoms that we see in a case of otogenic brain abscess. And lastly, stage 4 is the stage of late capsule formation, which is from day 14 and beyond. I have discussed all of these stages more in details as to what pathology happens during this time in the separate video that I have made on it. Now let's move on to the clinical features. Now we'll have to divide clinical features into 2 parts. One is the symptoms that you will be seeing as a result of raised intracranial tension, and second is a localizing feature that we'll see depending on which site of the brain that is affected in this case. First of all, because of raised intracranial tension, we have already studied all of this in the previous topics, that the common symptoms are headache, nausea, vomiting, lethargy, papilledema, slow pulse, subnormal temperature. Coming to the more important part, which is the localizing feature. If the temporal lobe is affected, in that case, the patient can have nominal aphasia, contralateral homonymous hemianopia, contralateral motor paralysis, epileptic fits, pupillary changes, and oculomotor palsy. I'll explain each one of these in the separate video that I have made on this topic. Whereas if the cerebellum is affected, the features that we see are headache, spontaneous nystagmus, ipsilateral hypotonia and weakness, ipsilateral ataxia, past pointing intention tremor, and dysdiadochokinesia. Coming to investigations, if you see, these are the CT scan. The first image that we see, this over here is a cerebellar abscess. And second one that you see is a temporal lobe abscess. And a common thing that we see is this presence of this ring sign. So the capsule is actually highlighted over here, and the central area is a hypodense area. That is a typical sign that we see in a case of brain abscess. MRI is usually more superior to CT. We also perform a CT temporal bone to evaluate the ear disease, and lumbar puncture is usually avoided here because of the risk of coning. Coming to treatment, there are 3 aspects of the treatment over here. In case, first of all, we start with medical treatment where we give IV antibiotics to reduce the infection and dexamethasone or mannitol to reduce the raised intracranial tension. Second is the neurological aspect where we have 3 options. One is we either perform a repeated aspiration of the pus through the burr hole. Second is excision of the abscess, and third is open incision of the abscess and evacuation of pus. Lastly is dealing with the otologic aspect of the disease. In case this has developed from a case of acute otitis media, we resolve it with antibiotics. And if it has come from a chronic otitis media, we have to perform a radical mastoidectomy. So that's all about otogenic brain abscess. Next, let's move on to sigmoid sinus thrombosis. Again, I've made a separate video on sigmoid sinus thrombosis where I discuss much more in details what are the features that you see, what is the pathology involved over here, but we'll go through it shortly in this video as well. So, sigmoid sinus thrombosis is an inflammation of the inner wall of the lateral venous sinus with the formation of an intrasinus thrombus. And this is also known as lateral sinus thrombophlebitis. So, what essentially happens here is, first of all, the outer wall. If you see in this image over here, the outer wall gets inflamed first, and there is a perisinus abscess formation that first happens. This then leads to the next stage where there is a case of endophlebitis, and a mural thrombus starts to form inside the venous sinus. Now, the thrombus that is formed inside now starts expanding and starts to occlude the lumen of the sinus and leads to the development of an intrasinus abscess. And once the intrasinus abscess is completely occluded, it starts to extend both proximally as well as distally. So that's a pathological process that happens in sigmoid sinus thrombosis. Coming to clinical features, there's a very typical fever that we see over here, which is known as the picket fence type of fever, accompanied with chill and rigor. If you see the picket fence, the image over here, you can see how it has a peak and then it goes down, and then it again has a peak and it goes down. This is the typical feature of the fever over here, and the reason behind it is the release of septic emboli into the bloodstream at different periods of time. Next, the patient will have headache, progressive anemia, emaciation, and a very important sign over here is Grissinger sign. This image over here shows the Grissinger sign where we see tenderness and edema over the mastoid, and this occurs because of thrombosis of the mastoid emissary vein. Other than this, we'll also see papilledema, tenderness along jugular vein, and two important tests that we perform here are the Toby-Ayer test and the Crowey-Beck test. Coming to investigating this disease, we'll perform a peripheral blood smear to rule out a case of malaria because of its similarity in fever patterns. A blood culture is done to identify the organism. When you perform a lumbar puncture, we'll see a raised pressure. X-ray mastoid and CECT brain is done. This is the image of a CECT brain, and the sign that we see over here, the green arrow pointing towards it, is the delta sign. And we can also perform an MRI. Coming to treatment, we'll treat it with IV antibiotics, perform a mastoidectomy and exposure of sinus. Rarely required treatment options are usually ligation of internal jugular vein. This is rarely done nowadays. It's only done when the patient does not respond to any other treatment. And there's also anticoagulant therapy, again, which is very, very rare. So this is all about the sigmoid sinus thrombosis. Last complication is otitic hydrocephalus. Now, what is otitic hydrocephalus? This is also known as benign intracranial hypertension. This is a disease which is characterized by raised intracranial pressure in the absence of any CSF findings. So you'll have raised intracranial pressure just like in all the other diseases we just studied. But in all of those diseases, we have seen that there's been some abnormality in CSF in all of those cases. Here, however, we'll find normal CSF findings. So the patient will present to you with a case of severe headache, diplopia, blurring of vision, and nystagmus. When we perform a lumbar puncture, we'll see that the CSF pressure exceeds that of 300 millimeter of water. So what is the normal CSF pressure over here? The normal pressure is 70 to 120 mm of water. Other than this, we can also perform an MRI. Coming to treatment aspect, we have the main problem over here is the raised intracranial pressure. So obvious answer over here would be to reduce the intracranial pressure. How will we do that? By using corticosteroids, mannitol, acetazolamide, and diuretics. Other than this, we'll also start the patient on IV antibiotics. And lastly, some surgical options are repeated lumbar puncture or a lumbar drain plus placement to reduce the CSF pressure, placing a lumboperitoneal shunt where the CSF drains into the peritoneal cavity, and last of all, mastoidectomy to deal with the ear disease. So that's all about the intracranial complications of CSOM. You can check out all the separate videos that I have mentioned here where I have spoken much more in details about those topics. If you have any questions on the topic or any other suggestion you have, please note them down in the comment section and I'll get back to you.